Early life origins of COPD. Chronic obstructive pulmonary disease (COPD). Introduction. In the United States, more people die from chronic obstructive pulmonary disease (COPD) than from any other condition except cancer or cardiovascular illness. What is COPD? It's a common preventable and treatable disease. Is characterized by persistent airflow limitation that is usually progressive and associated with an enhanced chronic inflammatory response in the airways and the lung to noxious particulates or gases.
In this video, we're going to look at COPD, chronic obstructive pulmonary disease review and introduction. COPD encompasses a number of diseases, including emphysema, chronic bronchitis, and chronic asthma. In this video, we will compare chronic bronchitis and emphysema. Let us first begin by looking at the signs of these. Patients with emphysema are also known as the pink puffers, because they have difficulty breathing, but are well perfused. Patients with chronic bronchitis are also known as the blue bloaters, because they are usually cyanosed. Some signs and symptoms in emphysema and chronic bronchitis include dyspnea, difficulty breathing, having a productive cough, and chest tightness. Patients with pure emphysema have a barrel chest, muscle wasting, as well as pursed lips. Patients with pure peripheral edema, EP, due to a potential right-sided heart failure. Let us now look at the pathology. Here I'm drawing a lung. Let us first begin by looking at changes that occur in emphysema. Pure emphysema mainly affects the functional units of the lungs, which are the alveoli. Alveoli are covered with elastic fibers which allow the alveoli to expand and recoil back, pushing air out as we exhale. However, in emphysema, what we see is a loss of elastic fibers. You also have alveoli. You can have something called air trapping, which is where air in the alveoli as we exhale, the recoil mechanism is not working. Chronic bronchitis, we have problems along the airway tract, specifically the bronchioles. Here I'm drawing a normal bronchiole with smooth muscle and mucus. In chronic bronchitis, we have smooth muscle hypertrophy and contraction, as well as mucus hypersecretion. This all leads to difficulty breathing. Some risk factors for COPD, both emphysema and chronic bronchitis, include smoking, advanced age, low socioeconomic status, genetic factors, condition, and developmentally abnormal lungs, which predisposes one to COPD. In a suspect include a chest X-ray, where findings can include a flattened diaphragm and hyperinflation.
Subtypes of COPD. Subtypes of COPD is emphysema, chronic bronchitis, and asthma. General COPD symptom is the dyspnea, chronic cough, sputum production, and additional symptoms is wheezing and chest tightness.
Bronchitis, inflammation of the, and it's said to be chronic because it causes a productive cough, which means it produces mucus, for at least 3 months each year for 2 or more years. Chronic bronchitis is actually lumped under the umbrella of chronic obstructive pulmonary disease, or COPD, along with emphysema. These two are different in that chronic bronchitis is defined by clinical features, like a productive cough, whereas emphysema is defined by structural change, likely enlargement of the air spaces. Coexist, probably because they share the same major risk factor, smoking, Other risk factors for chronic bronchitis include exposure to air pollutants like sulfur and nitrogen dioxide, exposure to dust and silica, as well as genetic factors like family history of chronic bronchitis. Become obstructed, and the lungs don't empty properly, and that leaves air trapped inside the lungs. For that reason, the maximum amount of air people with COPD breath, known as the F vital capacity. This reduction is especially noticeable in the first second of air breathed out, called FEV1, respiratory volume in 1 second, which typically is reduced even more than the FVC. A useful metric, therefore, is the FEV1 to FVC ratio, which, since the FEV1 goes down even more than the FVC, causes the FEV1 to FVC ratio to go down as well. Alright, so say normally your FVC is 5 liters, and your FEV1 is 4 liters. Your FEV1 to FVC ratio would end up being 80%. Now, someone with COPD's FVC might be 4 liters instead, which is lower than normal. But the volume of air that they can expire in the first second is only 2 liters. So not only are both these values lower, but the ratio is lower as well. Mark of COPD.
Pros and cons. Pros. Diagnosis: arterial blood gases, hypoxemia and hypercapnia. Cons is the risk factor or smoking. 80% have a history of smoking, pack history, packs smoke at daytimes during smoke, and cons is the obstructed way, impairment ventilation, and frequent infections. Thank you.